extraordinary moment. A moment in which science and technology have outpaced not only medical ethics, but also the capacities of the human heart to contend with the consequences of what we discover. I'm going to say that again. We live in a moment in which science and technology have outpaced not only medical ethics, but also the capacities of the human heart to contend with the consequences of what we discover. Today, our panel plans to explore perinatal technology and genetic testing and the ethical and clinical issues that arise from this evolving field. Throughout the ages, people have turned to religion and spirituality for guidance on how to live our lives, to make sense of our world, and to understand who and what we are as human beings. Today, genetics is attaining an increasingly venerated status. Genomic information is altering the way we perceive ourselves, providing unprecedented powers to glimpse what our futures might be, and sometimes offering discoveries that test the capacity of our hearts. This is perhaps no better or more poignantly illustrated than in the perinatal realm, where some expectant parents, looking forward to welcoming a new life with joy, are instead confronted with heartrending information that may bring mortality to the forefront, possibly a burden of agonizing decisions that need to be made, and most often a lot of ambiguity. Spiritual struggles are woven into the fabric of such situations as parents and practitioners alike confront ethical and existential questions while attempting to find meaning and make right decisions in the light of uncertainty. And so again, on behalf of the Spiritual Care and Chaplaincy Department, I thank you for being here for what I hope will be a very interesting conversation, and ask that you now please help me warmly welcome today's moderator, Katie Sagasser.
Good afternoon, everyone. Just pull up our slides here. I'm going to cut the mic really close to you because the sound isn't sort of bad. Better now? Yeah. All right, great. So my name is Katie Sagasser. I'm one of the 5 prenatal and preconception genetic counselors that work here at the hospital. So just a little bit of background about what the prenatal genetic counselors do here. We see patients referred from outside the institution and within the institution for a variety of indications, whether that's routine for us with patients who are high risk because of maternal age, or perhaps they have complex ultrasound anomalies that were either known about from an outside ultrasound or newly detected on our ultrasound. So the prenatal genetic counseling team here, together with our high-risk maternal fetal medicine specialists and geneticists, we try to provide anticipatory guidance to help parents and families navigate the complexities of these types of diagnoses. So I'd like to start with some introductions of our panelists today. Let's begin with Dr. Renee Ross, who's our neonatologist. If you could just describe your role at Johns Hopkins as it pertains to perinatal care.
Sure. Is this on? Yeah. So hello everyone. I am Renee Ross. I'm a neonatologist. I am also trained in palliative medicine, and so I do a lot of very serious prenatal consults, I guess I would say, here at Johns Hopkins. Typically what happens is either during the typical screening 20-week ultrasound, or sometimes if there's earlier concerns because of the family history of something or other concerns, a diagnosis, or at least a preliminary diagnosis, will be made, and then while more information is being gathered, I might be scheduled to meet with the family. So I could meet with the family kind of anywhere in the trajectory of uncertainty, all the way from we know absolutely what's going to be wrong with this baby and I know 100% what the prognosis is, to there's something wrong, they haven't met with the right people to do more testing yet, results are pending, whatever, and it's completely unclear what the prognosis is for the baby. So I will meet with the family sort of wherever they are and try to understand as best I can from them what they understand, what they're most worried about, what's most important to them, and how can we predict as best as possible what's likely to happen in the final weeks or months of the pregnancy, and then as if the baby is born alive, what will happen in the first minutes to hours to days of the baby. I'll pause there.
And then Jackie Britton.
Hi, I'm Jackie Britton. I'm a genetic counselor in the Department of Genetic Medicine. So I see patients sort of after pregnancy. We see patients anytime after birth. So I'm the primary genetic counselor here for our inpatient consult service, which is a team of our genetics physicians, our residents, and myself. And we see a lot of patients certainly in the NICU, but also patients throughout this institution at any age of life. You can have a genetic condition at any point. So a lot of the issues that we think about in terms of testing are specific sometimes to this time frame, but they can also stretch across the lifespan. And I think part of our case touches on that today. And in terms of, part of the role of the genetic counselor is to help make sense of this in terms of what genetic testing can and cannot tell us. Our testing is far from perfect, and it sometimes is even just, educating families and providers about what our testing can do and not do and what it can show us. And certainly there's a lot of answers, but I would say even more uncertainty than we have answers.
And then Kat, can you give us some background on how you as our chaplain have a role in this neonatal discussion?
Sure. So my name again is Kat Kowalski. I am the chaplain for our neonatal ICU, and I specialize in perinatal palliative care. And so I will actually receive referrals from any one of these people who are up here on this panel. Can come through genetic counseling, can come through maternal fetal medicine, can come through, thank you, fetal therapy. Neonatologists may reach out to me when there is a situation or a high-risk pregnancy where it's very uncertain how this baby's trajectory will be. And so I will get involved prenatally, oftentimes sitting in on a prenatal consult with a neonatologist, which is helpful for me as I'm not a medical person to actually hear what the family is saying and what the doctors are saying to this family about the prospects for their baby. And then I will work with them moving forward to help them actually create a birth plan and provide that information to our medical team so that we have a sense of what this family's values are. And then I will follow them once that baby arrives and is in our care, depending on how they progress. Sometimes they move on to hospice care, and I can help facilitate some of that. Oftentimes, many of these babies that are coming for these particular conditions, lives are very short, and so I will be here to support families through that process. And every once in a while, of course, we have a celebratory time where, in that space of unknowingness, things are better than we hope. And so getting to see those families go home. But really here to kind of just provide this continuity from prenatal diagnosis through whatever this child's life will be, and supporting these families spiritually, emotionally, and helping them think through things about what would be important to them, what are their values.
And then Dr. Janice Henderson.
Hi, I'm Janice. So I'm a maternal fetal medicine subspecialist, and I probably see the patients first. Not always, sometimes they come to genetics first. But I look after the mom and the baby before birth. I see patients sometimes pre-conception who have histories of problems such as this one, or I see them during ultrasound when we actually make the diagnosis and have to give the bad news. And then to help coordinate their care after a diagnosis is made. I also work on labor and delivery, so I might be actually doing the delivery of this patient. And I think that all the time, and what everyone does, is trying to make the patient truly understand what the problem is, what the expectations are, and for us to try and understand what it is they want. I think that's vitally important in dealing with a patient like this, that they recognize.
Thank you. So now that everybody's settled in, hopefully everybody got some lunch, we're going to review the case that was distributed. So just some background to the case that we've selected today, in which the names are changed. We want to point out that with the recent advances in prenatal sonographic technology as well as genetic testing, we're experiencing an era in which we have a high level of prenatal diagnostic yield, but just because we can reach a prenatal, perinatal, neonatal diagnosis, that doesn't always necessarily mean that we have a clear-cut prognosis. So anytime there are these situations in which families who are expecting a new baby are faced with uncertain outcomes for that new baby, there can be an extraordinary amount of pressure for the parents as there's a transition from prenatal care into neonatal care or whatever comes next. So let's review the case of Lila and Peter. So this is a couple who are in their late 20s. They have recently transferred their obstetrical care to Johns Hopkins Hospital, coming from an outside center, so they had not been previously seen before at our institution. What we know about the couple as they're coming in for this transfer of care is that Lila's pregnancy with a female fetus is complicated by multiple anomalies. So the couple is known since about the mid-gestation point from the anatomy sonogram that the fetus has hydrocephalus, so increased diameter measurement inside the ventricles of the brain. The fetus is missing thumbs on both hands. The fetus has club feet bilaterally, and there's significant growth restriction. So at the outside center, we know that the family has been informed of these anomalies. They elected to undergo an amniocentesis, which is a prenatal diagnostic technique to withdraw amniotic fluid and test cells that are coming directly from the pregnancy. The testing that's been performed so far is called a microarray, examining all of the fetal chromosomes and confirming that the chromosomes are normal, there are no disease-causing deletions or duplications. So while we know that the fetus has a normal microarray, that doesn't provide any explanation for the clear anomalies on the ultrasound. So as Lila and Peter come in for their transfer of care, there are several appointments that they've been scheduled for, including their transfer OB nurse visit, a detailed anatomy sonogram for us to establish, do we see any additional anomalies? Are there other things that we need to be aware of as we're planning for Lila's delivery? A fetal MRI. The couple will also meet with one of our prenatal genetic counselors to try to help, again, with the anticipatory guidance piece and determine if there's additional genetic testing recommendations we can provide. There will be a consultation with maternal fetal medicine. There will be as well a consultation with neonatology and the perinatal palliative care chaplain. So quite a day, or several days. So as we mentioned, we know that there are these outside ultrasound findings, but as the couple comes in for their transfer of care sonogram here, our sonogram, which Dr. Henderson or one of her colleagues would read, and then the fetal MRI that's performed, finds not only the same outside anomalies, but there are new findings. So the pregnancy is now identified to be complicated by severe fetal hydrops. Hydrops is an anomalous collection of fluid within several bodily systems, so usually within the lungs, the abdomen, underneath the skin, perhaps along the back of the neck. And in addition to the finding of hydrops, there's also a severe intracranial hemorrhage. So, Dr. Henderson, in light of these types of new findings, what could a patient reasonably expect that conversation to look like in the ultrasound room?
Well, it's a tough conversation. A patient is coming in, just transferring her care. She's already been through a lot. She's got, I think, high expectations for this baby. And we have to give some pretty devastating news that their baby is really not doing well. At 34 weeks, the baby's hydropic. We think there's a bleed in the brain, and the baby isn't really moving. So it's kind of a critical point that we have to start to make decisions about, should delivery happen now? Should we try and get more information by getting the MRI? Should we be evaluating the baby to see if the baby's anemic? So a lot of things are going through my brain. But I think what I start out by asking the patient is just, what do they understand before they came in, and did they see anything new when they were looking at the ultrasound? Because often when I walk in the room after they've been scanned for an hour and a half, patient already knows something's up because the sonographer has been looking at certain images over and over and over, and our sonographers aren't allowed to really talk to a patient, but they're being quizzed by a couple all the time, what are you seeing? And often when the sonographer isn't saying anything, that's usually a bad sign. So once I understand what they understand, and I have to say, that there's new things. Your baby isn't doing very well today, and I'm very concerned. And then we have to get into a conversation about what do they want to do. And I know that they can't make that decision right now, and I also know that we need a lot more help in making that decision. And I think getting more information, the consult with genetics, getting the MRI would help us make that decision. But this patient would be admitted to hospital from this point, and we would coordinate all of that care with the anticipation that she might even be delivered that day. Also with high drops, I have concerns about mom's health, that she could develop preeclampsia, what we call mirror syndrome. And so she would need to be evaluated for blood pressure, some labs, etc. When she goes up to labor and delivery, we would put her on a monitor to see how the baby's doing, and we'll cross our fingers that the baby's has a reassuring tracing so we don't have to make a decision right then and there. I'm going to assume for the point of this case that we're not making that decision immediately because we want to have the input of other people and have the discussion around that. So these are tough conversations to have, and usually the couple breaks down, starts crying right away, and they often don't take in everything that I tell them. So it needs to be reinforced over and over and over the things that we're seeing and what this all means. We should go on further.
That's very, very helpful, and I think you touched on an excellent point about how decisions can't always be made on the spot, both for the purpose of the fact that the patient can't reasonably take in this level of information so suddenly. I know that when we meet with patients, many times they'll describe, the ultrasound room is already dark, but when you come in with that news, oftentimes it just feels like you're blacked out. Do you even really hear anything? So there's that level of, can we reasonably make decisions on the spot from the patient perspective? But up to your point, there's also some level of coordination that has to happen with, you mentioned, what if mom develops preeclampsia because of the high drops and mirror syndrome? The baby's only 34 weeks, so presumably that's on the early side for delivery, and how do we navigate what's best for a very, very sick baby with potentially a mom who could become very sick? So what type of process, this is a free question for anybody, what type of process is involved in planning these types of deliveries or neonatal care for infants who are anticipated to require this high-level multidisciplinary care?
Well, I'll start. If the mom has preeclampsia, she needs to be delivered. So then it would become more of a neonatal problem rather than making plans up front.
So in case people didn't get that, that's an ethical thing, right, about who trumps baby versus mom, issues trumping before birth, so mom's issues trump, right? So the question about preparing, I think when these scenarios happen like this, that it's at 34 weeks or when a baby is viable but premature, we have a discussion between OB and NICU about what makes sense. So we would anticipate at 34 weeks the baby's likely to have some complications from prematurity, which could make the underlying problem seem even worse at birth, and that could complicate decisions that we make around as soon after birth about how severe the baby looks. Maybe some of those symptoms are really about prematurity versus the underlying problem. So we often have complex discussions where we try to figure out what's the best timing here. So obviously if there's an emergency for the mother, or if the baby looks really bad when we start the tracing, then the decision's a little bit easier because it looks like the best thing is probably to try to get the baby out. But barring that, then we have to have some complex discussions about pros and cons of delivering the baby prematurely. And then in terms of, how do we prepare for the neonatal care of this baby, I would say that the more time we have, the better. And so ideally, we wouldn't be doing this today, even if we can wait until tomorrow so that we can get more information. We can think about juggling the other things that are happening in the ICU, because this is probably going to be a sick baby who's going to need a lot of care. So if we already have 3 cardiacs that are being induced today, and we've already accepted a transfer from another hospital of a congenital diaphragmatic hernia, those sorts of things come into play as well. So what are the systems issues that make us either more or less able to take care of this baby right now?
I wonder, are there any other specialties for which you would want to get another opinion on for the purpose of this baby's immediate care? For somebody presenting with hydrops and a head bleed and hydrocephalus, not moving, not a trick question, but oftentimes there are multiple specialties involved.
I guess genetics and neuro are the 2 that come to the top of my list. So is there any insights that I don't personally have, or other questions that I haven't yet thought of myself that could be helpful in counseling the family? And I'm particularly thinking about, we start to get into pretty serious decisions about what to do if this baby does not do well at birth. So let's say the plan is for the baby to be born tomorrow because the mom has preeclampsia, or because the baby starts to look poorly, even worse. And then the question is, what are we going to do for the baby when the baby is born? And so if it turned out that the neurologist were to come and say, what, that MRI looks even worse than the radiologist called it, and I am seriously worried that this child has a really profound neurologic injury, for some families that would change what they wanted us to do at the time of delivery if the baby was in distress. And so neuro and genetics would be helpful to me in that way.
I'll just add one other thing, that we also have to have a conversation with the parents about mode of delivery at this time. And that comes into a lot into prognosis, because if they elect to just, what's the right word, to do compassionate care, to not do anything heroic for this baby, then we would offer them the option of just being induced rather than having a C-section if the baby showed distress during labor. And lots of couples will make that decision, especially if this is their first baby, if they don't want to take on added risks in a subsequent pregnancy. So it's just another whole conversation that has to be had during this time.
I think that is one of the things that's so challenging in a situation like this. There's so much ambiguity, because what we're talking about, there's so much uncertainty in terms of what this baby's outcome is going to be. And so as practitioners, to be trying to guide them in these decisions, do you do a C-section if we're not really sure that this baby's going to survive? Is compassionate care an okay option for this particular family or not? Is our, once this baby comes, as a team, are we obligated to do medical technologies because the baby's doing okay? Or is it okay to do medical technologies, or is the outcome going to be so poor? Why are we doing these things? So trying again to guide these parents and for them to be making decisions in light of so much uncertainty is extremely challenging.
Dr. Anderson, can you speak a little bit to the point of, would we think about the risk benefits of a C-section for a baby who we're worried about not doing very well? So I think in general, there can be a lot of misperceptions about, oh, it's just a C-section and they happen all the time. So what are some of the things that are important ethical considerations in this scenario?
Well, C-sections are pretty normal. We do C-sections all the time, and our section rate here is about 30%. So I just talked to moms about what that would mean in subsequent pregnancy. It increases her risk of needing having a placental problem of and it's just more risk for her in terms of infection and bleeding, etc. I think for some couples, they really want a live-born, and to guarantee a live-born in this circumstance would mean almost for sure doing a C-section, because this baby is not going to tolerate labor, given how ill it is right now. So I think we have to figure out what their real wishes are about that. A lot of couples think that, a C-section doesn't have any risks, but not just in the future pregnancy, but in this pregnancy, there are more risks of infection and bleeding. They just have to be aware of that.
There's also some, in some scenarios, there's also the issue of maternal sedation, are moms okay with the possibility that they would be sedated when their baby was born if it turned out the baby only has minutes or over an hour or two to live? And so while often C-section can be done without changing mom's mental status, it's not always. And so some families feel very strongly about that as well.
If it's done non-emergently, sedation would be very unlikely, but if we got into a scenario where the baby suddenly status changed and we're doing emergency C-section, she might actually be put to sleep.
So in the setting of a baby that might only be, breathing for seconds or a minute, asking the couple, some of the birth planning process that Kat was mentioning could be really, really important. What are your wishes? We keep, I think, alluding to the fact that we just don't know how this baby is going to do, right? So that can potentially be aided through the input of genetics. Not always, but in this scenario, I think it is definitely relevant. So I want to bring in some of Jackie's input too, because with this type of fetal presentation, if I were seeing a couple prenatally, or if she were seeing them surrounding the perinatal course, the differential diagnosis is so incredibly broad for what could have caused these types of anomalies. In the genetic counseling conversation, we kind of tend to have two main portions of this discussion, right? Like, what is going on for the patient who blacked out in the ultrasound room because she was so traumatized by the information, and then why is it happening? And that's where I think we really try to help identify the cause. So I wonder, Jackie, if you can talk a little bit about some of the pros and cons of more prenatal testing, if there's DNA left over from her amnio versus postnatal testing.
Yeah, I think, part of the initial conversation is even, for some families, it's even, why is genetics relevant? Like, what does genetics have to do with this? Why are we talking about genetics when my baby has anomalies? So you can just bring it into the conversation that this could be a DNA difference that has caused this child's anomalies, and those changes could happen sporadically, or sometimes those changes could be inherited and running in the family, which could have broader familial or even reproductive risks for other relatives or other family members, future offspring. So sometimes it's just, figuring out why genetics is fitting into this case, which some families know and some families don't. And then in terms of testing, I think it's important to highlight, testing that was already done and what it did or didn't tell us, what next testing could be considered, and really thinking through what some of those pros and cons, the limitations are of that testing. So, this is a mom who had a previously normal test, so there are, in theory, some cells that are remaining, but at 34 weeks, really, no genetic testing is really instant. So at 34 weeks, for someone who's potentially likely having an imminent delivery, any testing that we're doing in that moment, either if it's on the saved amniocentesis cells, we're not getting a result that's going to be back in any, not even in the hours. Genetic testing usually takes 3 to 4 weeks, often at minimum. And broader, more comprehensive testing can take 2 to 3 months in the case of pull-ups of pregnancy. So I think it's thinking through, okay, with the family, this could be genetic, but what can I actually do about this right now? We can think about testing, but it might not actually really impact any of these other conversations that we're having in terms of caring for the baby at this moment, in terms of decision making. So those decisions are still going to be made without a confirmed genetic diagnosis. And if it's not, for families who also have had no previous testing, we can do testing after delivery, and thinking through what those complications or implications would be. I think in this case too, highlighting the fact that as you said, the differential diagnosis is broad. And I might be able to think of my top 2 or 3, but often I don't have a specific one that's, I think it's this and absolutely it's a straight answer. So I think there's a lot of ambiguity that comes from that, even for providers who want to have a definite answer, and our testing is not instantaneous or often quick enough to give us a quick answer that's going to impact how we're taking care of the baby, this very sick baby, in a matter of hours.
We, I think, really live in the world of rare disease too, so many times the diagnoses that might seem to fit the clinical presentation the best, you have to ask yourself, oh gosh, what are the odds? This is a condition that there's only 3 other people out there that have this, but
we're always surprised with results that, we either thought it was this and we get a negative result, or vice versa. Oh my gosh, it's this, I never would have thought that. Because it is complicated and we're learning new information all the time. I think that the other 2 points I was just going to add is, sometimes we see families who have not had any prenatal imaging or evaluations, and so still having to deal with a very sick baby in the moment is also relevant for genetics. And thinking about that diagnosis that could, again, potentially in the most helpful way impact future family decisions. And there also could be the potential to learn additional information after delivery about additional features or symptoms that this child has that wasn't detected or known prenatally, which could change some of what our suspicion of the underlying condition is. So it's important for us to know sort of, is there anything different that you're seeing after the baby is born compared to what was known prenatally? In terms of cost, insurance and coverage is variable for genetic testing. What some people might be able to have done during pregnancy on like an outpatient basis can actually be very different than what might be done on an inpatient hospital setting. So what mom might be able to do under her pregnancy testing might be limited in terms of insurance coverage, and we might be able to send more testing once that baby is born in the hospital setting. That's somewhat also institution specific. But some of, if we're thinking about whole exome sequencing, which is, a test that we think is the most comprehensive to evaluate all 20,000 or so genes that we have, even though we don't understand all of them at this point in time, that can be $5,000 to $8,000.
I think at delivery, we just err on the side of saying it will be covered, and we draw the blood, and then we figure that out afterward.
Yeah, I tried. And it's better to have it's better to have a sample than no sample, right? So some of the urgency, especially if this was an unknown complication, a not known sick baby, is I can't do any testing if I don't have a sample. So some of that urgency is, please, at least let us know that this baby is here, that this family is someone we should meet. And if this baby is very critically ill and is only going to live for minutes or hours, and I can talk to them after. But if you don't let us know that this baby is here and this family needs genetics, and if there is no sample, I might have no testing to do.
And on the prenatal and postnatal side, both the issue of cost can make genetic testing completely inaccessible for some patients. So I think kind of thinking creatively sometimes about, well, maybe the resources are not in place that we can reasonably pursue an $8,000 test for this patient right now. But what if we could consider the option of DNA banking so that in the event that the family had a recurrence of the same condition 2 or 3 years later, maybe sample from the first affected child would be available, banked. These are some of the, for the future kind of discussions that can go on in these sessions.
And I don't know if people are aware of it, some of the most expensive, so whole exome sequencing, which can be very, very expensive, and which we would never want parents to get a bill. There's a group of us that will talk sort of stat when there's a request for whole exome sequencing. So, and on that group of people who join the call are people like Jackie, people like myself. I think in that call I officially wear an ethics hat. Neonatologists, people from the lab, And we sort of had a real-time discussion about this patient and this testing, and does it make sense? Is it right that we would send this very expensive test that might have the possibility of ending up being a very expensive bill for the family? Is there any other option? Is the reason for sending the test clearly going to be something that changes outcomes, et cetera? So we, at this point, have been doing that now for maybe 2 or so years.
The other thing that I just want to bring up is, we're kind of talking about all of these kind of as separate issues. And if you can imagine that this family has come to the hospital for some appointments to get some additional information.
Getting ready to deliver the baby.
All of a sudden, mom is inpatient. They've got an 18-month at home. They've just moved here to Baltimore because they've transferred their care. They don't know our team at all. They don't have a support system here. We're asking them about delivery. We're asking them about genetic counseling. We're asking them about their insurance. We're trying to give them options about their baby. All of this is going on at one time. So even though we're here talking about it in kind of these sections, I just want to put that out there, that this is really what this family's experience is trying to navigate all this, as you said, in a state of too much information, and trying to make decisions. And how do you ethically make decisions when you're in that state and having to deal with so many moving pieces at once? So it feels important to just say that. Like I said, it is nice to sit up here and kind of talk about all these individual things, but in a lived experience, this is all happening at once to a family.
In preparing for this, I realized that a quote that I often use in a lecture that I give is from the Journal of Clinical Ethics, so it's appropriate. And this is from the author Mary T. White that says, because genetic testing often raises issues that are at root existential, having to do with illness, suffering, loss, and death, we can anticipate that spiritual and religious values can influence how some people respond to genetic information. So I think that it's very appropriate, your point of there is a common denominator in all of this process, which is this very, very spiritual element, human element of how are we going to do all of this.
Absolutely. You get questions, why me? Why my baby? Why is this happening? What did I do to deserve this? How are we going to find meaning in this? How are we going to find our strength in this? Where do we find hope in this? All of those questions really raised to the surface and impact decision-making as well.
So tell us a little bit more about your role in the process of creating a birth plan. What does that look like, and how can you introduce some of these really, really heavy ideas about meaning-making to these families?
So I think a lot of what I'm trying to do when I'm working with families certainly is to understand their values, understand where they're coming from, because that's going to influence their decision making, that's going to influence how they're going to navigate this particular situation. And of course, generally if there's a baby coming, there generally are more than one person involved, and so not only am I trying to find out what their individual values are, but what are their values as a couple, how do we navigate the situation so that they end the situation intact. And oftentimes they're coming at it from very different places. In this particular case, so we have a dad who wants as much information as he can possibly get. He's very concerned about his 18-month-old daughter, and what does this mean for her? What does it mean for her genetically and her future? What does it mean for her if she had a sibling with disability? He wants as much information as he can possibly get, and of course we don't have that information to get, so to be standing in that place of uncertainty is really challenging. You have a mom who, according to our case, had lost her father a month ago, so she's already in a state of deep grief. She is overwhelmed with information, doesn't want any more information. Although she hasn't been religious most of her life, this is really bringing up these questions, and especially having lost a parent a month earlier, kind of wondering about trying to have more faith and trying to be involved more spiritually, and we would do this. We would do everything for the daughter that we have. Why wouldn't we do everything for this particular daughter? And so, again, trying to kind of hold space for each of these individuals as they navigate this, and help them find their way to some kind of common goal. And part of that is through writing a birth plan. With a birth plan, because we have so much uncertainty, we can actually discuss all the different options of what may happen. What would it look like if this baby arrived and died in the delivery room? What would it look like if this baby arrived and was showing some effort? Would they want her taken over to the NICU? What would that look like? what would it look like if we got her to the NICU and she ended up having long-term disabilities or issues that would keep her in the hospital for a long time, or that she would need care for her life? What would that look like? And so writing a birth plan, we can actually write their ideas or what they would like for each of those scenarios. And I think what it does is it really provides families an opportunity to kind of stand in those places. Again, we have so much uncertainty. We don't know which way this is going to go, but it allows them to kind of feel into it. And in feeling into it allows them to kind of discuss what would be important to them and to write that down and have that information available, which then you can get to the medical team. Of course, in a situation like this, if we're really in an urgent position, it becomes more challenging. And so trying to hold space for them and help them to maybe perhaps even just to surrender whatever's going to happen is going to happen, and so to kind of surrender to that. So I think that's kind of, I think, some of the main ways that we do it. The other thing that always seems important is, as we weigh what these families want, to let them know that there are things that we can do to, however long their child's life is going to be, that we can bring value to it, that we can make it a sacred time. I think sometimes how we present it or how parents hear it is, we can do everything or we can do nothing. And as a parent, you want to feel like you're a good parent, so of course you want to do everything. But if we start talking about some of these other things that are possible, would you like your child to have a blessing? Would you like the siblings to come and visit? Would you like footprints? Would you like family members to come? You start to kind of put these things that families can do. All of a sudden, you're weighing things in a different way. It's not all or nothing. It's, we're going to be doing something. We're going to be loving this child. And really assuring these parents that really there aren't right decisions. There's just hard decisions. There's what's best for their family, what's best for them. There's loving decisions. So whatever they choose for their family, it's a loving decision, and to kind of hold that space for them to discover that.
You had mentioned a point that I want to make sure we get to. I want to have plenty of time for audience questions as well. About how the family also needs to consider what this experience might mean for their older daughter. And so I think that the case that's happening with Lila and Peter, here's a pedigree, their family history that the genetic counselor would take. So through this collection, the team realizes that there's not really any other birth defects that seem to be related to the baby's presentation with the absent thumbs and the high drops, etc. But there's this family history of male breast cancer and pancreatic cancer, high cholesterol, things that maybe you may or may not see in other people's family history. So, Jackie, how would you synthesize this type of a family history with the fetal presentation, this long list of differential diagnoses, and then what genetic testing results could mean for various family members?
Yeah, I think with this family history and these anomalies, it would occur to me that maybe somehow this is all related, and I think I would try to express that to the family. There are conditions that could tie. While it might seem unrelated to you, the occurrences of cancer in your family, in this case perhaps the Jewish ancestry, since there are some inherited cancer syndromes that can be more common in certain populations, that being one of them. Some of those in some more severe manifestations can cause birth defects as well. So is this something that's coming from a combination of mom's family and dad's family together that could be resulting in these anomalies for the child? But at the same time, to say these things could be separate and unrelated, and that our testing may or may not give us some clues when those results come back. But I think I would be proactive in mentioning the possibility that all of these things could be tied together, because if we were to uncover that there is a cancer predisposition type condition in the family, that could have implications for both mom and dad themselves in terms of their own medical care, as well as all of their relatives. These things can be passed down through the family. So their relatives in terms of parents' own siblings, their parents, previous generations, as well as this couple's 18-month-old daughter. So this results for this sick pregnancy could actually have much broader familial implications. And I think it's really important to make that explanation beforehand because it can make conversations and explanation of results sometimes at least a little bit easier in terms of when you get those results back. So I think it's important to go through those possibilities up front. In terms of the testing also, I think about, just what kind of results could we get back? We get a positive result, meaning it's clear cut, we found the answer, sort of, we're done in the sense of this is the answer, now we can test other relatives. We can get a negative result, meaning we found nothing. A negative result doesn't mean it's not genetic, it just means it's something that didn't show up on this testing. And the implications for that in future pregnancies can be really difficult. If I don't have an answer for what caused the anomalies in this case, it could be genetic, and I don't have a really good test to offer for a future pregnancy. That can be very challenging. And then there's the possibility of a result that's uncertain, adding even more uncertainty to this situation. You get a genetic result that says, we found this difference in the DNA, and it's a difference we've not seen before, and we don't have enough laboratory or clinical evidence to say whether it's truly disease-causing and positive, or it's a benign variant that's nothing. So you can have all of those, sort of spectrum of results, and sometimes you might get multiple results on any one given genetic test. That it could be, a combination of different things. So I think trying to set the stage as much as possible with what we would consider that to be like your pre-test counseling or pre-test consent, so people can at least hear this information, because you may not hear it, you may not remember all of it, but at least if you've heard parts of it, it might make a little bit more sense when we actually get results back, and we can discuss it again at that point.
Can you speak a little bit to the difficulties of informed consent for maybe a couple where collecting the sample and sending it off for genetic testing needs to happen urgently, but with so many other things going on, maybe they are in a state of shock and just cognitively it's really difficult to process things like incidental findings that could come from genetic testing?
Yeah, so, right, so in terms of incidental findings are things that we think of as sort of separate from the primary reason for testing. So I think two things. So one, in terms of, these urgent type cases, and some of them are urgent cases where these things are really unexpected, or things are happening, or things are going more poorly than expected. I'm just saying, you can collect that sample. You can talk to the family in a day or two. Please at least let them know that we're thinking about testing, so that you've at least planted the seeds and they're not like, who am I when I'm calling them in a day or two. And so some of it doesn't have to be done in that moment, because there are other things that might be more important in that moment. But at the same time, I think it is important to convey, from the team, that we're really suspicious or really worried that this could be genetic, and that might have broader implications for your family, not just for this child. And so if you do want to try to understand this for your broader family, please make sure that you follow up on this. So I definitely talk with families, in the days after a baby might have passed away, about testing that we can do. We do kind of have a very narrow window about when we can practically do that testing, though, because the hospital and insurance doesn't like to pay for testing for someone who's passed away, to be honest. Secondary findings, for whole exome sequencing, where we can learn something that's sort of totally separate or incidental, I do think, families can have some time to figure that out, in a sense, like, we can do the rest of this testing even if you're not ready to make a decision about that, but I need a decision by the time our results are going to come back. So these results often are going to take 8 to 12 weeks, 2 to 3 months. So I think it's okay if we make a decision, at least on the purpose of the testing, is we want to proceed and accomplish this. And if we need to circle back in a few weeks about what this other option is, we can certainly do that, and do that for families as well. We also have families, I feel like, go either way. They're in this moment and say, I can't possibly think about any other information. The only thing I'm focused on is what's going on with my child, and don't tell me anything else. And that's okay. We cannot learn that information. Or families can approach it from the other way and say, I'm already doing this test, or trying to find out as much information as possible, or knowing my family history. I want you to tell me everything that you could possibly tell me within the limits of what you're testing.
I know we have a handheld mic. I'd love to open the floor up for other kind of clinical, ethical questions that you've seen. There's a hand in the back. Do you want me to come? There you go.
I don't know the legalities, but, and I'm sure it varies state by state, but what about termination? Do you present that as an option? How late are you legally able to present that, and how would you present that if you are able to present that?
Thank you. Is that a question directed just for anybody? Okay. So typically at 34 weeks, that's not generally an option in most states. There are exceptions to that, but at Hopkins, that wouldn't be an option at this stage. I think that some of our providers had mentioned, talking about options of comfort care. Is that something that?
I would just add to that, so at 22 weeks, when we did find these anomalies, that would have been an option in the state of Maryland and many other states.
Correct. Yeah, at the outside center where these anomalies were originally detected, as long as it were somewhere in Maryland, that would have been an option. But by the time the baby gets here at 34 weeks, that's not something that Hopkins would be able to provide.
But someone, hopefully, maybe might have presented that as part of their options at 22 weeks on those anomalies. I would say that is discussed in sort of ultrasound appointments or genetics appointments at any time when there might be severe anomalies that are uncovered, if the gestation in that particular state allows it.
She does have the option of doing nothing, and the likelihood is that this baby would die in utero, and then she would be delivered with a stillbirth.
Just to go back to your earlier point about the option for termination, isn't it the case, though, that the mother had potential serious complications from this pregnancy, and in that case, if the mother's life is at stake or well-being, then termination is an option even in the third trimester. Isn't that correct?
But if she had preeclampsia, we would deliver her for her sake. And in a way, you could call that terminating a pregnancy, but we deliver moms all the time, 24 weeks, 26 weeks, beyond for preeclampsia. And you're putting the baby at more risk by doing that potentially, but that's the only cure for preeclampsia is delivery.
But arguably in this case, with the child as compromised as it appears to be, could one make the case that termination was also a reasonable option in this case?
I think at this point we would not call it termination, so we would call it delivery and then provision of palliative care alone for the baby. And given just what we simply have on the paper, I would say I'm not sure. So what would typically happen in this scenario is we'd sit down and really talk it through. If there's any ambiguity about it, then as typically what will happen in the neonatology group is we'll get together as a group and discuss it and try to come to a group agreement about whether or not palliative care alone would be an option. I've seen those conversations travel the spectrum. So sometimes it's super easy and we hear the data and we look at the images and we talk it through and we say, oh yeah, absolutely, we can all get behind this. Sometimes we look at it, we hear it, and we say, you know what, we think there's really a chance. We need more information at the very least before we would support that. So we would say, no, we wouldn't support that, but we will support getting as much information as we can quickly after birth and then reconvening to make a decision with the family about whether continued care is still the right thing to do or whether stopping then might be an option. And then sometimes we disagree as a group about whether or not palliative care alone is a reasonable option. And our strategies for what to do next about that is that sometimes we ask the ethics team to come help us think through it. Sometimes it's a matter of just more information. We need more understanding, and if we're lucky enough, we'll get that more information through yet another ultrasound that tells us something is either more or less severe. And if we can't have an agreement, then we generally try to honor the parents' choice, even if some of us might disagree with that choice.
I will say too, obviously termination is an area that for parents oftentimes brings up a lot of spiritual and ethical distress. That they're thinking, my microphone, I don't know. think my battery died, talking too much. I was going to say that I just want to bring up that termination is a point where, for a lot of parents, it becomes spiritually and ethically distressing, that they view themselves as a particular person who perhaps would not choose that. But what makes all of this very interesting is now with all of this technology, all of this information that families are receiving at 20 weeks, 18 weeks, 20 weeks, 22 weeks, all of a sudden they have a lot more information to be having to make decisions about. And again, one of the things that I try and work with families, because if they've gotten to this point, this is a wanted pregnancy. They're coming to Hopkins for a second or a third opinion, and they're finding out this devastating news that their child's life is not going to be. It's going to be a devastating life. And so parents sometimes do choose to end the pregnancy. And for me, part of what my role is, and I think it's important as a spiritual person in some ways to be able to hold that space for them, is in saying, you are grieving parents. You are grieving parents. This was a child that you wanted, and you are making the best decision that you can in the moment of uncertainty. Many families are choosing termination because they don't want their child to suffer. This is not a life that they wanted for them. And so I just want to bring that up, that for parents too, this is an area that really churns up a lot of things, and it's new in the sense that all of this technology, genetics and sonographic things, like I said, we have so much more information within their pregnancy that they're having to cope with, still with the uncertainty of we don't really know what the final result will be. Just agree with that.
So I was wondering what happens in the situation where mom and dad don't agree? Is there one viewpoint or one parent that sort of trumps the other one?
In terms of genetic testing or?
In terms of like let's say a severely affected child where you don't know what to do after birth. Do you do any interventions or not?
That never happens. So I'm a firm believer that communication is the solution to most of this around decision-making and values and conflict and trust and what's best for our family. So if we're super lucky, we've got enough time to work through that. And for some families, they can work through it in a day, and some families need a month. So every family is different, but if we're lucky, we've got enough time to work through it. Kat works right through it, Dr. Henderson sees them again, they see me, we all sort of nudge different pieces of the puzzle together and give them different space, and many families can come to a similar place in the end. When there is a true conflict and we don't have time, then in general we will proceed with resuscitating or intervening, because we can undo that, right? We can stop therapies once they've been started, but if we don't start them, then we can't walk backward from that decision. So we will do everything that we can to get to the parents into agreement, if at all possible. If it is not possible because this is happening too fast and they haven't had time and we can't establish relationships, then in general we will resuscitate and then hope that we can continue with lots of aggressive communication interventions with them. I would say that the vast majority of times we're able to get parents on the same page. The second most common thing that happens is that typically the male partner, the father of the baby, will say, do whatever she wants. So those are the two most common scenarios that I encounter.
So in the situation that the baby would survive after birth, and then the family decided, okay, I'd like to take this child home, is that legal? Because in a sense, like the child without proper care, without hospital care, would inevitably sort of pass away in the home. Would that be an option for them to do? Would the hospital team object to that?
I guess I'll hedge and say, there's not enough really granular detail here for me to make big claims. Is there ever a possibility for a family to bring home a baby to die? Sure. We have perinatal hospice, we have neonatal hospice. We're very happy to help the family connect with the hospice team so they can bring a baby home to die, if that makes sense along the trajectory. We would always prefer they go home with hospice so that the baby can get medications if the baby has any distress, so that the family has somebody to call in the middle of the night when they freak out. I think that what I see a lot is that these families' goals and values do a little bit of this during this period. Think about postpartum hormones alone, right? So there's a lot of this, and so hospice is really valuable in having a 24/7 person who understands the family a bit and their goals to call when they start to have small changes of mind to things or have questions or freak out. So we would always want them to go home with hospice. We can also bring additional supports to the family, psychosocial supports to the family, child life, and can be a support to the family when the baby dies. So most people having babies are young. And most people who are young have not had someone die in their presence. So having a baby die at home in your presence can be super stressful, even if that's your goal. So again, having the hospice team who can physically be with you if that is important or helpful during that time. So yes, for sure, families can bring babies home. So if a decision has been made that if the baby survives after birth and the decision from everyone is that the prognosis is so grim that we all agree that not, for instance, giving the baby a feeding tube or not providing respiratory support is all a reasonable thing to do, then we would do our very best to help them go home with hospice.
We have about 1 minute left, and that's generous. Any last questions? Thank you all for coming today. Thank you so much for your consideration of this difficult topic that we are honored to get to explore with our patients every day. Wish you all the best. Just a reminder again about the event with Danny Shapiro on January 13th. You need to register.